Okay, good morning everybody, and welcome to this session on pulmonary embolism, on let's say the acute pulmonary embolism. And this is indeed a rather new field in the endovascular treatment, and it's for me a pleasure to have here some speakers from the Netherlands, from Maastricht, which is very close to Belgium, where I'm coming from. So I think that my co-chairman, Dr. Sanne de Boer from Maastricht, will introduce our first speaker.
Yeah, good morning, everyone. Thank you for having me here. I'm very honored to stand here next to my colleague, Professor Geert Maleu from Leuven. I'd like to introduce the very first speaker, Christine Winkers, a colleague of mine from the Maastricht University Hospital, from the specialty of vascular medicine. And the first talk that she's going to give us is how to set up a pulmonary embolism response team. Christine, thank you.
Thank you very much for the introduction. And thank you for the invitation also. So I will talk about PERT. So they asked me how to set up a PERT. I don't have any conflicts of interest. So it's morning. I'm a mother of 2 children, so I often find myself baking pancakes, and I can easily share with you a recipe for pancakes. And although I think some of you might need to practice a couple of times, at the end, everybody can make pancakes following a simple recipe. So it's very easy. In the same manner, I can also share with you my recipe to set up a PERT. That's easy. However, in contrast to our kitchens, which are more or less the same organized, hospitals are organized very differently. So you need to make your own PERT. You need to adapt it to your own hospital. So that's maybe not something that you want to hear from me, but that's true. But there are some key ingredients which I can share with you. So a PERT needs to be a multidisciplinary team. You need to have different experts so you can give comprehensive care to the patients with a pulmonary embolism. A PERT needs to be 24/7 activatable. So you have to think of that when you ask people to join your PERT. PERT must do a rapid risk assessment and then give an individualized treatment plan. So a PERT needs to have access to different types of treatment. If your hospital does not have different types of treatment, then it makes no sense having a PERT. PERT should always do quality improvement and in best way also contribute to science about pulmonary embolism. So the first thing you can do is identify your stakeholders, and they are also different for different hospitals. So who in your hospital is taking care of pulmonary embolism? Is it the same when they have a low risk and a high risk, or is it a different doctor? Do you have a hospital where you have ECMO? Because if you have ECMO, you should also ask them to join your team. Do you already have like mechanical thrombectomy or not? And if you don't have it, who in your hospital can do so? Is it the interventional radiologist? Is it the cardiologist? So find your stakeholders. That's the first thing you should do. And when you have them, you might end up with quite a complex collaboration, so it's very important that you have a leader. In our hospital, it was the vascular medicine. It doesn't matter who it is, but you need somebody to coordinate it, to make decisions, but also to make sure that every stakeholder's expertise is utilized in the best way to give the best care to the patient with a pulmonary embolism. So in our hospital, for example, people with a straightforward pulmonary embolism, they come to the pulmonologist, which is not in every hospital the case.
Christine, can I ask you a question? Or maybe, who already treats pulmonary embolism in the room? Can I see some hands? See some? And who wants to start treating pulmonary embolisms? Not all the rest. Can I ask you where you're from? Your industry. Hi, good morning. Can I ask you where you're from?
Finland.
Finland. And is this an active discussion in your center?
In my center, but internal medicine is taking care of this complex.
Yeah, and for are you having a discussion on whether or not you want to start treating the patients with mechanical thrombectomy or a different interventional treatment?
Actually, we already do, but it's between intensive interventionist and internal medicine right now, and cardiologist a little bit. But I'm very interested about how it's organized in other hospitals. So.
Okay, thank you. I'll leave you alone now.
So I move on to the next step, and the next step I think is to educate each other, because you all know something about pulmonary embolism, but you all have a different expertise, and you can learn a lot from each other. Interventional radiologists can tell how is the procedure performed, what are the pitfalls, when is it technically feasible, things like that. In our case, like I told you, the pulmonologist takes care of the straightforward pulmonary embolism. When you have a high-risk pulmonary embolism in our hospital, they go straight to the intensive care unit. So our pulmonologists, they underestimate mortality rates of pulmonary embolism. So for us, it was very important that the intensive care unit doctors share their data, because that was striking how many people still died nowadays from a pulmonary embolism. And of course, the ER about the logistics, and I made an update of all the literature. So once you have done that, you have to make a protocol. And the nicest thing is when you get a protocol from another hospital. I had it too, but I have to say it doesn't work. You really have to make it yourself and just start. So who can activate PERT? Is it only physicians? Can everybody do it? And when do you want them to activate? We made a chart, so it was a bit easier. You cannot read it, but just to say, when there is an intermediate high pulmonary embolism with some additional risk factors, please activate PERT. After that, you have to think, who is the one that is activated, and make it simple. In our hospital, the vascular medicine specialist already has a 24/7 pager for anticoagulant therapy questions, so we coupled it to that one. That made it very easy. Then also, how does it take place, the PERT meeting? And of course, on a Monday at 3 o'clock in the afternoon, it's quite easy. You just phone each other and you say, shall we discuss this patient? But mostly they arrive on Friday night at 3 o'clock, and then it's a bit more difficult. So we made a Teams, and we have every first of the month, every physician who has something to do with PERT has a meeting at 8 o'clock in the evening. So everybody knows, for example, this is in June. When there is a PERT case in June, just go to the 1st of June and go to that Teams meeting. So that makes it easy to have this discussion, and it works very well. And then, of course, how do you get your advice? What do you want? What do you want to? Let me say it the other way around. We made it that we need 3 specialists before that we give an advice. And then, of course, the logistics. And make it very detailed, because the fellow at the intensive care unit, he or she needs to know what to do in the middle of the night. So you have to be there for the details. Once you have done that, you are probably busy with PERT like a couple of months, and you can dream about PERT, but the rest of your hospital doesn't know it yet. So you have to communicate and educate with your community, and use as many things as possible. So we put it, of course, on the website. We had a lot of education sessions in different places in the hospital, but also in the region. We made a poster that is there on the intensive care unit, and everybody can look at it. We have Q&A document for the fellows on the intensive care unit, and in that way we try to educate everybody. Then there is a problem with pulmonary embolism, and it is that it doesn't happen on a daily basis. So the learning curve is not very steep, like in stroke, for example. So you have to repeat the education, and also staff members, they change, of course. So that's another reason why you have to repeat this. You have a lot of PERT members, so they should all be an ambassador of PERT in the ideal world, and they should do some micro-teaching in their own community. So the interventional radiologist, Sanne does it. He does some micro-teaching with his colleagues, and when I'm sitting with my colleagues, I do the same thing. So we try to infiltrate in the hospital. So once you have your protocol and PERT is working or running, you should keep having regular meetings, because probably you need to change some things. We also did it. For example, in the first protocol, I included that every patient with an intermediate high-risk pulmonary embolism should be discussed with PERT. After 1 week, I got so many phone calls on patients who were really stable that I thought this is not going to work out. So now we added that those patients need to have an additional risk factor, like a tachycardia or respiratory failure or collapse or high lactate levels. You have to evaluate the process, but also the outcome. And at the beginning, that's just case by case. But after a year, you can also look at case series. And I think maybe Sanne will share some of the data that we have. But it also motivates when you see that you're having success. So that's a good thing to do. And then I think a lot of people also in our hospital, they also are conservative. And they say, oh, PERT, they work outside of the guidelines. It's not good. I think that we advise in advance of the guidelines. So we have to see what is coming in the guidelines based on indirect but still evidence. And I think it's important that PERT also contributes to that evidence so that what we are advising now will be in the guidelines in the future. So my concluding slides. If you think of setting up a PERT, don't wait for a recipe, just start. Make the first step, identify your stakeholders, and move your way upwards until you have a successful PERT. Thank you very much.
So thank you very much. Are there questions from the audience? If not, I've a question. So when you have a patient who comes in on a Friday night or a Saturday afternoon, how are you then communicating within the PERT group? Do you have a WhatsApp group or by mail or by phone? How are you communicating within the group then in, let's say, outside the typical 9 to 5 hours?
Mm-hmm. I made it look a bit simple, but it's not that simple as I made it look. So they phone the vascular medicine specialist who is there 24/7 at home, and then the vascular medicine specialist phones the interventional radiologist, the pulmonologist, and the intensive care doctor and says, please meet within 10 minutes in our pre-programmed Teams meeting. We already have it pre-programmed on the 1st of the month at 8 o'clock in the evening. Everybody knows what that meeting is for. And if somebody sees that we have a meeting and wants to join, fine. But we just phone a few people who should join, and then we discuss the patient. We also have an app, a Silo app for doctors, in which you can share information that you cannot share by regular WhatsApp. And sometimes we do share like CT scan or laboratory results, or what I often do is I phone my colleagues and ask them to join, and in the meanwhile, I already type the case so they can think.
Yeah. But it's very important that you find something that works within your own center and your own team, because when we started out with the Silo app, we started discussing cases within the app, and there was not much control. So we switched to, okay, it's fine to discuss cases and outcomes within the Silo app, but you do, like Christine say, also especially during the on-call hours, you need to identify certain stakeholders and call them and tell them, meet us in the pre-programmed Teams meeting, and that works really well. And then usually we're there with 3 or 4 doctors that are on call, and then there we have the actual policy discussion. Okay, what are we going to do with this patient?
Okay.
I had a question here.
Yes, Gijs Bloemsma from UMCG Groningen. First of all, thank you. You made me a bit more enthusiastic again. We tried to create a PERT team like a year ago, but in the lead there was a pulmonologist, and they were no go. They were not really interested. So maybe I should try it again with the intensive care doctors. That's the first
in the Netherlands, I don't know why. Pulmonologists, they do pulmonary embolism. And I don't know why, because they are not interested in the right side of the heart. And that's what this is about. You need somebody who is interested in right side heart failure. It's not a pulmonologist. It's an internist sometimes.
They only come when it's a really rescue procedure. But the question I have, can the PERT team also be activated by the hospitals in the region? Because we get a lot of questions from the hospitals in the region, what to do for a specific patient. How do you take care of that?
We have of all the mechanical thrombectomies that we've done, half of them were from the region, so indeed we can. I have to say that when a doctor from the region calls you, they tend to say the worst numbers that they have seen in the patient. And then you sometimes end up with a patient that you think, I would never have thought of doing a PERT. It can be that the patient stabilized over time, that can be, of course, but that's sometimes a bit a problem. And the other thing that might be a problem is when they need to go on transport, they are not stable. So is it ethical to put somebody on a transport when he or she is not stable and you can do systemic thrombolysis in the other center? So that's the reason why we only do this for patients who have a contraindication to systemic thrombolysis. Just because it's not yet in the guidelines and you don't know if the patient maybe is better off in the own region with systemic thrombolysis. I'm not a fan of it, but the transport makes it a bit more difficult, I think.
Any other question? I was interested, what's it like in on the other side of the pond? Because that's something where PERT originated from, early 2010 or 11, I believe.
Yes, thank you. There is no consistency in the United States. There are some very well organized centers that have reported their results. In others, like centers like ours, we have both the cardiologists, the interventional radiologists, and the vascular surgeons all doing PE interventions, mostly organized through the pulmonologist, but there is no organized plan at all. So we have tried several times, and there's been a lot of resistance from several people, but it's very center specific. Some places are outstanding, others, like our center, not so well organized.
Yeah, you really need, I think, good leadership because it's such a complex collaboration. Yeah.
Okay, so I think that's the right moment now to switch to your second presentation, which is in fact how we really have to manage patients with acute pulmonary embolism. So I'm very curious how you are managing this in the Netherlands.
I might have a different interpretation of the title, so I stay away from the really acute ones because I think there are a lot of colleagues after me who will talk about it, so I will just talk about regular pulmonary embolism. Again, I have no disclosures. So for me, it's a mission impossible to talk in 7 minutes about management of pulmonary embolism, but I'll do my best. So as you all know, venous thromboembolism is the combination of deep vein thrombosis in which there is a clot formed in the deep veins of the lower extremity, and it can loosen and travel all the way up through the heart, through the lungs, and then causing a pulmonary embolism. So actually this is the same disease. So a lot of signs or a lot of studies, they are done in VTE and not in PE. So some numbers, 1 in 2 patients a year will have a VTE, and that's a bit abstract, but it's recalculated that there is a lifetime risk of 8 to 9%. It's the third leading cause of vascular death, and it's the leading cause of in-hospital preventable death, so it's still very important. So when you open a textbook, or I just went to internet, of course, then pulmonary embolism, it said it typically presents with an abrupt onset of pleuritic chest pain, shortness of breath, and hypoxemia. Whereas in the real world, there are really 50 shades of pulmonary embolism. On one hand side, you have the completely asymptomatic patient who went for a CT scan in a follow-up of some malignant disease, and then as a coincidental finding, they have a pulmonary embolism. And they can be really big, those coincidental findings. And on the other side of the spectrum, you have the patient that enters with a cardiac arrest. So, and everything in between, of course. And because there is such a heterogeneous presentation, also the mortality rates are very heterogeneous, from 0 to 1% in the very low risk group up to more than 50%. I think Leuven presented the data of the patients that came in with a cardiac arrest and the resuscitation, and there was a 67% mortality, so that's really a dangerous disease. So why do people die? It's all about the right side of the heart. The pressure increases suddenly, and as a result,
No idea.
And as a result, the right ventricle becomes dilated, it cannot contract that much, there is less output, and then there is less output on the left side, and then patients get in shock. So if we want to predict which patients do need some more attention, then you use these signs. Of course, you can look at shock, but then you already have the ones that are really, really bad condition. But you can also look at cardiac markers and right ventricle dysfunction. So a clinical score that we often use is the PESI score, as you might know. On the left-hand side, you can see the parameters that are included, and on the right-hand side, you can see that indeed with increasing PESI score, mortality rates increase and even up to 27% in the highest group. So the ESC guideline also uses all those parameters to stratify from low risk to intermediate risk to high risk. And you have to keep in mind that only 15% of the patients that we see are in the intermediate high risk and the high risk. So it's a small group that we are really worried about. So then the treatment. So based on the risk, we of course decide, can a patient go home and be treated safely, or do we need to admit the patient to the hospital, maybe a medium care, maybe an intensive care unit. However, in treatment in the guideline, although we have this really broad range of complex presentation and a broad range of prognosis, treatment is really simple. You either treat with anticoagulant treatment or you have the reperfusion therapy, and then in the ESC guideline they still advise systemic thrombolysis. And yes, in the high-risk group, systemic thrombolysis halves the risk of mortality, but the price is high. There is a 10% risk of major bleeding, a 1 to 2% risk of intracranial bleeding. And that's also the reason why a lot of doctors don't give systemic thrombolysis, even not when a patient has a high-risk pulmonary embolism. So they tried also to give the systemic thrombolysis to the group that has the 15% mortality, the intermediate high-risk group, but there the benefit does not outweigh the risks because of still the high risk of bleeding. So for that group, we only have the anticoagulant treatment. And I hope in a couple of months or so that you have a PERT who can advise about that group. So I would like to focus on the other group so you know how they are treated when it's not that acute. So this is the first trial on pulmonary embolism published in The Lancet, in which they included first 19 patients that they did not give any treatment, they just prayed, and then 16 patients who were treated with heparin. And then there was a mortality rate of 26% in the untreated group versus 0% in the treated group. I have to say a PE-related mortality because patients died of other reasons. So that was the first time that anticoagulant treatment was used, and we still use it, of course, in all patients with pulmonary embolism. Here is a study in which they included 400 consecutive patients with a pulmonary embolism, and then they looked at mortality rates when anticoagulant treatment was started immediately at the emergency department or when it was started only in the hospital. And you see that there was a large difference in the mortality rate. This is not randomized, there is some bias, but still there is a large difference. And still nowadays, it's striking how many people consult our PERT and they haven't started anticoagulant treatment yet. That really remains the most important treatment. You should never not give it unless there is maybe an intracranial bleeding or something like that. But it's very important that you start it soon. And that's maybe also the reason why the DOACs are very good for VTE. They have a very rapid onset of action. And there are a lot of landmark trials with more than 27,000 patients included who show that DOACs are more or less as similar as warfarin. So they are now first choice in all patients with VTE. So 10 years ago, we switched from warfarin to DOACs, but we were still treating those patients for 3 to 6 months, after which we decided to stop treatment. And what you see on the left-hand side, the upper one, oh, I'm sorry, I need to go back. You see that there is a recurrence rate of 20% in patients who have an unprovoked VTE. That's really high. Whereas when there is a major risk factor, you think of like hip surgery, then there is a 0% risk of recurrence. And on the right-hand side, it's a study with a longer follow-up, 10 years, Brandoni in Italy. You see that after 10 years, 50% of patients have a recurrent VTE. So the short duration is not enough. So from that time on, we treat patients with an unprovoked VTE lifelong with anticoagulant treatment. And as I already told you, when you give anticoagulant treatment, there's always a price to pay, and the price here is bleeding. So now we are shifting towards a lower dose. We try to treat those patients with the lowest dose as possible. And this study was published in The Lancet this year. They included all patients with a high risk of recurrence, and they treated either with full dose or reduced dose. And it was a non-inferiority design, and actually the low dose was not non-inferior, so it is better to give a high dose. But if you look at the absolute numbers, then the risk of recurrence was 1.8 in the high dose and 2.2 in the low dose, and it was in 5 years. So remember, I just showed you the 20% recurrence rate in 2 years. So this is really, really effective treatment, even the low dose. And what you see on the right-hand side is that you have much less this is clinically relevant, non-major bleeding, but also major bleeding. It's much less in the low dose. So I think it's good that we go that direction. So to conclude, when we have somebody with a pulmonary embolism, we first start with the initial treatment, which is mostly a high dose of a DOAC. Then we change to the normal dose, and that's to stabilize the clot and to treat the clot. And then after half a year, we decide, is this a high-risk patient or is this a low-risk patient? And based on that, we continue either indefinitely or we stop anticoagulant treatments. So to conclude, anticoagulant treatment is very effective for the treatment of venous thromboembolism, and it should be started immediately. The majority of patients, then anticoagulant treatment is fine and you don't need expensive treatments. You do need them for a small part of patients, however. And if you have a patient with an unprovoked VTE, the risk of recurrence is extremely high. So I think it's important that we keep on treating them indefinitely. Thank you.
Do we have any questions from the room?
Thank you, Christian. Very nice talk. I particularly liked the initial reference to the Barrett study from 1961 that I haven't seen for a long time. But I was going to ask you, you mentioned the PESI score, and it seems to me that all of these predictors, whether it's the RV-LV ratio, the PESI scores, the negative predictive value is very, very good. The positive predictive value is very, very poor. If you look at the RV-LV ratio, the positive predictive value for death is only about 6% or so. So I think it's very good at deciding who is going to do fine. What do you use personally in your risk stratification for picking out those patients who are not going to do fine?
Oh, this is not scientific, what I will tell you now. But I think if you work a lot with patients with pulmonary embolism, you recognize them immediately. You think that this is not okay. So, but I think when you have really like tachycardia and the blood pressure is lower, that's not good. We have seen in our cohort also. And then the ones that are neglected in the ESC guideline is the one with respiratory failure, of course. If you have oxygen saturations that are low, then that's also not good, and those patients are also at high risk. And I think the risk score and everything, it has a high negative predictive value, not a very high positive predictive value, but it adds on. And that's, I think, important to keep in mind. Because 27% mortality, it's still not 100, but you want to do something, no?
And I think also in those cases, we generally, because in the guidelines they say, okay, if you have an intermediate high-risk patient who is stable, you can just monitor them, and if they don't improve within 12 to 24 hours, then you can still escalate to an intervention. But typically in those patients, either we treat them immediately, if there are certain parameters that we don't trust it, or we just say, let's reevaluate in 2 or 3 hours, and if then there's no any improvement, then we still escalate to mechanical thrombectomy. Yeah.
Because that's also what you say. Sometimes that's why the intermediate high risk, it's when you have some right ventricle dysfunction and you have cardiac markers. So there's a lot of patients who have it, and you see it immediately. You enter the room, they are just talking to you, and they are like, okay, I have this. Then you know this is not the patient that I'm worried about.
Okay. Michael, can I ask you, how do you manage the patients in your center?
So we have a very interdisciplinary approach. As you just mentioned, we have a PERT team. So the patient comes into the emergency department, and the patient is at least intermediate to high risk. The PERT team is directly involved, and my department, the interventional angiology department, is responsible for thrombectomy. So we are not doing any longer any CDT therapy. We go for mechanical thrombectomy if the conclusion is that we should treat this patient based on cardiology, emergency medicine, and intensive care unit discussion within the PERT team.
Questions from the room?
I've maybe a small question, so quick answer also, because this is a conference on mainly on peripheral vascular disease and on devices, etc. So is there still a place, and if yes, what is the place for inferior vena cava filter in acute pulmonary embolism today?
I think there is a new place. I forgot about the place of vena filter. Oh, short, I need to do it short. Yes, there is. When you do a thrombectomy in a patient who has a contraindication or who has a bleeding risk, then please put a filter, because otherwise the week after you're busy again. We had it now for 2 times, so we always think of the filter when we do the thrombectomy. Yeah.
Okay. Other questions? If not, then we can go to the next talk, which will be given by my co-moderator, Sanna de Boer. Well, he will explain us how he is doing mechanical thrombectomy. Please, Sanna.
Thank you so much. This is just a short video of all my colleagues and the team who I work with. And we're going to talk to you about on catheter-guided thrombectomy and what the current commercially available treatments there are for mechanical thrombectomy, and at least how we do it in Maastricht. So I have no disclosures related to this talk, and Christine already talked to you about many different anticoagulation, but the treatment of PE, of course, has many different options, and I'll be focusing on these 2. Over the past 10 years, and my co-moderator will probably speak more on all these studies and their outcomes, but especially in the past 10 years, there has been an explosive increase in research being done in the treatment of PE, which I think is a very good thing. And what you can see in the future, we can still expect a numerous amount of trials that will be published in the field of PE. These are the currently, as far as I know, commercially available devices. So we have the flow retriever from Inari. This one, AngioVac from AngioDynamics, the flash catheters from Penumbra, and of course CDT with either a normal thrombolysis catheter or, for example, the ECHOS catheter from Boston. And the main difference, I think you can divide all the devices into 2 categories. You have the CDT, for example, the PITO and now the high PITO trials, they investigate CDT, but the main difference between CDT and mechanical thrombectomy is the speed of offloading the right heart. So usually, typically in CDT, it will take 6, 12 to 24 hours before you can see any effect on the right heart, whereas in thrombectomy, the effect is often immediate. And also good to know that a large part of VTE is lysis resistant. So this is the reason why, at least in Maastricht, we didn't choose for CDT, but we chose thrombectomy. I have a case. I think this was a case done in August. 67-year-old woman. Had a recent fracture of her left leg with external fixature, was referred to us from a different hospital, and she had sudden shortness of breath, desaturation, elevated heart rate, blood pressure was normal, and the lactate was still was a little bit higher, but not too high. Oh wait, this one. Troponin was elevated and the NT-proBNP as well, but she was having a hard time breathing. So she had Optiflow 50 liters on 50% oxygen. So she was having a really hard time breathing. She couldn't have a normal conversation with us. So this was a patient where we decided, okay, we're going for mechanical thrombectomy immediately. This was her CT scan. You can see major clot burden on the right side, a little bit less on the left side, dilated right ventricle, and then also the septum is a bit flattened, all indicating elevated pressure on the right side. So what do we use? I usually start out with a 5 or a 6 French sheath, a hooked pictal catheter to navigate through the right heart, hydrophilic guide wire, Amplat super stiff, a pressure measurement kit, very important to measure the pulmonary artery pressures before and after your thrombectomy, and of course your thrombectomy kit of your choice. We always use ultrasound to access either the femoral artery or the femoral vein. There are several techniques for crossing the right heart. We use a hooked pigtail. In my experience, generally, the steeper the angle of the hooked pigtail, the better and the easier it is to navigate through the right heart. You can use a Grolman catheter, or you could inflate a small balloon catheter and then just let it carry by the flow. Then this is usually typical the route that you need to navigate. And then here you can see, so we already have a hooked pigtail catheter in the right ventricle. And then we, by rotating it counterclockwise, you rotate it to the anterior side, and then usually it will flip up. On the way up, there are certain things that you'll encounter. Rhythm issues, often when you're manipulating with the catheter in the right atrium or right ventricle, you can see some changes in the rhythm, and then often the ICU nurse, who's often in the room with the patient, asks us, "What are you doing?" And then, and sometimes the patient can feel it as well. But when you stop, any arrhythmias, they usually stop immediately. They don't often get too much. I never encountered any major rhythm issues, but as soon as the ICU nurse says, "Okay, it's getting a bit too much now," then just pause, and then you can retry. Also very important, sometimes you can see it on CT if there is, for example, an ASD or a patent foramen ovale. We did encounter that one time. This was a different patient. We made an angio and we're like, that's not right. And the catheter now is in the left pulmonary vein. So we made an angio, and then you can see the left ventricle filling and the aorta. So we knew, we didn't see it on CT, but we knew we passed through the septum somewhere. Back to our case. So this was the angio, comparable to the CT scan. So on the right-hand side, the right lower lobe, there's no perfusion, and there's also a major embolism here in the lower lobe, left lower lobe. And what I do then, so we measure pulmonary pressures. Often the left pulmonary artery is the easiest to catheterize, but now the wire went to the right side, so we just figured, okay, the clot burden on the right side is the largest, so we'll just go to the right side. So we move the pigtail catheter to the right side, and then you exchange for, we use an Amplat super stiff. So over there, and then we exchange for an Amplat super stiff. And what you'll see, so I make a short J-tip on the end of the wire. But what you'll see is that the wire, because it's quite stiff, it wants to move and push everything up. So here you can see that. And then I stopped, and then you can use a trick. You can like pre-shape the wire. Also, when you have a very stiff aortic bifurcation and you need to do a crossover procedure, you can also like pre-shape your exchange wire, and then it will be easier to pass. And that's also something you can use when catheterizing the right pulmonary artery. So now I think I'm happy with the way I shape my wire here. And then slowly moving it up. And now you can see it makes the angle. So after that, we exchange the pigtail catheter and the 5 or the 6 French sheath we have in the groin. So in our center, we use the kit from Inari, the FlowTriever, and now we exchange for a 24 French seal that comes with the kit. So here you see my colleague putting on the seal, or the sheath. Sometimes patients can feel a bit pressure. We always do our procedures under local anesthetics as much as possible because we feel that adding, especially general anesthesia, will only add additional cardiovascular risk. So we always try to do them under local anesthetics. So here we place the 24 French sheath. Yeah, and then we go to the next slide. And then you need to bring up the 24 French catheter like this. And when you do that for the very first time, it's quite impressive on how big it is. So here we slowly advance the 24 French catheter, and now you can see the size of the catheter in relation to the heart and the pulmonary artery. It's quite big. And usually when you want to make this angle, patients sometimes can feel slight pressure on their chest. And I can tell you the very first time when you do this procedure and then you do this maneuver and patients are starting like, oh, doctor, I feel so much pressure on my chest. It was scary. But sometimes they feel it, sometimes they don't, but it will always pass. But do it slowly. So then we take out the dilator. You always leave the wire in place. And then you start, you hook up the syringe and then you do the suction. So here's a video of how it works, because I think these are better than what I can show you real time. So you hook up the syringe, you create a vacuum, and then you aspirate the thrombus. What I like about this system is that they have a cell saver. They call it the flow saver. And you basically filter the blood through the filter, and then you just give it back to the patient. So I think the average blood loss that we have on this procedure is maybe 100, 200 milliliters. Unfortunately, this wasn't a very impressive yield, but sometimes the filter is completely full. And those are always very gratifying moments, to be honest. And then we give back the blood. Oh, I need to start this one. This is sped up a bit because of the time. And then, so this was, I think, after the first or second time we did a thrombectomy, but we really wanted to get out the lower part of the thrombus as well. So we slowly advanced through the right lower lobe, and then just stepwise, and after this we went to the left lung. And then you just slowly perform your thrombectomies to get everything out.
So by the way, you have different sizes of aspiration catheters going from 24 to 20 to 16, depending on the level of your pulmonary artery where you want to aspirate, of course.
Yeah, I have to say though that in practice, I think in maybe 80% of the cases, we only use the 24 French system. Sometimes they also, we're going to the next slide. And just, so this was where we started out, and then this is how we ended up. So we have a nice perfusion of the right lower lobe. We have a much better perfusion now as well of the left lower lobe. And then this is the yield of this patient. So pulmonary artery pressures weren't too high when we started out, so it was 30/12 with a mean of 20. Only a slight reduction, although this wasn't too high to start out with. But you can see the insane amount of thrombus that you aspirate. And what you can also see, you can see the white parts, and those are the very chronic parts that will never, you'll never treat those with lysis. A different case, but basically the same effect. So this was before, and this is after thrombectomy. So in my experience, it's a very good way to treat patients. Yes, there is a learning curve, but now I think in general we usually take little over 1 hour when we do our cases to treat both sides. And this was what we got out. And again, can go back. Here on the right side, you can see the organized thrombus that probably was migrated from the leg up. Always remeasure your pulmonary artery pressure afterwards. Of course, remove the 24 French sheath. We always place a cross-mattress suture and a small pressure bandage. And of course, Christine will start the anticoagulants. And just some brief clinical outcomes from the last 14 or 15 patients that we treated in Maastricht. So the decrease in arterial pulmonary artery pressure that we see corresponds with what's being reported in the literature. So on average, we see a decrease of 10 points, although I'm not really sure how much it will predict the outcome of your procedure. Usually what you see during the procedure is that you see the heart rate going down, you see the saturation going up, patients will start to talk more, and for me those are usually the best predictors to see how successful your procedure is. So of the last 14 patients, after we did the thrombectomy, 4 patients don't need any additional oxygen. 4 patients only needed, or 10 patients only needed nasal oxygen. 1 to 2 liters in 4 patients and 3 to 4 liters in 6 patients, which is a vast difference from starting out on OptiFlow 40, 50 liters with 30, 40, 50% of oxygen. And none of the patients had a need for any hemodynamic support after the procedures. And sometimes they stay 1 night in the ICU, and sometimes they just get discharged to the normal ward within a day. Questions?
Thank you, Sanna. Well, there's another question already.
Thank you very much for a great presentation. I want to ask you about the timing. I mean, when we have a patient, for example, in the legs with iliofemoral DVT, if we take everybody to clot removal strategy, obviously that was not the best thing to do. But so now we do give anticoagulation for a while, and if no response to 48 to 72 hours, then those patients are the ones most likely to get PTS. I wonder if for PE, do you allow some time for anticoagulation first in the intermediate risk, of course, patients? Do you allow for how much time would you give before deciding to intervene?
Yeah, excellent question. Thank you. Generally in patients with intermediate high risk that are clinically doing fine, and you don't feel the need for performing a thrombectomy, we always start out on anticoagulants, and we always re-evaluate after 6 or 12 or 24 hours. So that's generally the time that we give ourselves to see which way it's going. If a patient remains stable and does not improve clinically, sometimes then you can still have an indication for thrombectomy. And as Christine said before as well, sometimes because nowadays, currently, as the guidelines are right now, especially patients with respiratory failure, there's no place for those patients. So if you already have a patient who maybe is still an intermediate high-risk patient on the parameters, but you can already see that they're having a really hard time breathing and they're in the category of respiratory failure, then we escalate much quicker to interventional therapy. Yeah.
Sanne, you in your talk you
Yeah.
you told us that it's a very safe procedure, and indeed that's also our feeling, that the risk for having real major adverse event is very low. Can you confirm this? Because this is, I think, one of the very important points for those who want to start a program for mechanical thrombectomy. That is the fact that the procedure itself, if you're doing it following the guidelines, it's a very safe procedure without risk of major complications.
Yeah, I think the most important thing is that you are familiar with catheterizing the right heart and doing having access to the right pulmonary artery. So I was trained in a center where we treated a lot of pulmonary artery vascular malformations. So during my training, I already regularly catheterized the pulmonary artery. And I think this is one of the main aspects that you need to learn during your training, that you can safely catheterize the right pulmonary artery and that you know your way around. If you look at the data on, for example, in the FLASH registry from Inari on this specific device, the all-cause mortality within 30 days was 0.8%, and none of it was device-related. So, and there were no pulmonary perforations. We had one major groin bleeding. I think it was the first or the second case. We only did a suture in the groin and we didn't put any compression bandage on it, and then we had a major groin bleeding. But that's, I think, and I'm looking at Christine, but that's one of the few major complications that we, oh yeah, but that was in this patient. Yeah, so the patient I showed you, I didn't put in the whole case because we didn't have that much time, but this patient was referred to us from another hospital, and so we didn't put in because she still had DVT in her, on the iliac and the femoral. We didn't put in a vena cava filter because we would start out on anticoagulants. She got transported back to the referring hospital. And we did tell them, well, if you want to stop the anticoagulation, please contact us again, because maybe there's an indication for a vena cava filter, because they still needed to perform surgery on her left leg. Unfortunately, they stopped anticoagulation because they wanted to perform surgery. We were not contacted if there was a need for a vena cava filter. So 2 weeks later, she was referred back to us with major PE again. We did a second thrombectomy. I think that was in the middle of the night, unfortunately. I performed the second thrombectomy myself as well. And then, of course, I placed a vena cava filter because this is not going to happen again. So then I placed the vena cava filter. And then, unfortunately, a day later, she also had a stroke. So we also performed a stroke thrombectomy. But I think she recovered without any sequela. So that's really nice, yeah. But that basically sums up the major complications that we had. But I think it highlights the importance of communication, not only within your own center, but also with the referring center, and the amount of education that you need to perform in centers within your region on how to manage these patients.
I fear another question.
Brian Manning, Cork, Ireland. Thanks for your presentation. My question kind of relates to what you just discussed. If you have a patient who has an iliofemoral or iliocaval DVT, and these patients are obviously quite sick, Do you address that at the same time, or do you just put in a filter and leave it? What's your general approach?
We have not encountered iliocaval DVTs. I think often if patients have iliofemoral DVT or iliocaval DVT, by the time they get presented for a mechanical thrombectomy in the pulmonary artery, it usually everything that was there migrated into the pulmonary artery. But we did encounter one patient still had a right-sided iliac DVT. We accessed the other groin, but we just left the DVT on the right side in place to treat with anticoagulants. In Maastricht, it differs a bit. If patients get referred to us with iliofemoral DVT from the vascular surgery, then we usually perform a thrombectomy. If patients are initially being seen by internal medicine, they just start anticoagulation. But I'm looking at Jorinde, but that sums it up. Yeah. But during a pulmonary artery thrombectomy, I think the main aim of your procedure is to perform the pulmonary artery thrombectomy and not necessarily focus on the iliofemoral DVT. Yeah.
Thank you very much for this nice presentation. My question is about thrombosis of IVC. Maybe I missed this point. If we have iliofemoral and extended to IVC, and by this technique you can do it from the jugular or from other point. Thank you.
Yeah, I know, but I have not accessed the jugular vein. I know in Leuven you sometimes do. Maybe in Arndt, Mike, have you experience with jugular vein? No?
We did a few cases indeed by from jugular vein, but of course we've did 24 French, although flexible catheter. Well, it's still not that easy to do. But there are some patients indeed where it is impossible to go from the groin to the pulmonary arteries, and then of course you have to go through the jugular vein. That's correct. So it's technically feasible, but it's more demanding and much more difficult.
Yeah, just to comment on this, I think on the way up, IVC indications is also very well addressed with the 24 French catheter. So when we have IVC involvement, we use the 24 French catheter as well. It's very effective there as well. I'm not sure if it's on label, but you can use it easily. 2 questions. 20 French device, when do you use it? Do you see even an indication for the 20 French flow retriever system? And second, especially for the distal pulmonary part, do you use the disc in these indications?
The 20 French, the straight version, I hardly use. I think it was designed for people when they had relatively small pulmonary arteries. I see someone saying time, we need to move on, but I'll finish this. Is that you also have the 20 French curved, which is really nice. It's like a 20 French and has a very steep curve, and it's really nice sometimes to access the left pulmonary artery because of the angle. And often for the more distal part, I sometimes use the 16 French. I hardly use the discs. Sometimes I've used the discs once, but more as an anchor to pull up the 24 French system. Yeah. Okay.
And these discs might be also interesting for these emboli which are more chronic or really difficult to aspirate. Then you can really try to use these discs.
Okay. So we'll move on to our next speaker, my co-chair, Professor Geert Maleu. And he's going to talk to us on the outcome of these procedures.
Okay, thank you, Sanna. So it's already said that acute pulmonary embolism is an important cardiovascular risk after myocardial infarction and stroke. And let's say this also already mentioned by previous speakers, that anticoagulation and including also systemic thrombolysis is the mainstay of the medical treatment. However, when you use thrombolysis, then of course there is a significant risk of more than 1.5% of intracranial bleeding. And that's the reason why mechanical thrombectomy devices have been developed to overcome that problem of bleeding. What about catheter-directed thrombolysis? Well, I'm not going back to the 60s, Christine, but I'm going back to the 80s. Why? Because it was my professor in vascular medicine, Professor Verstraeten, who worked in Leuven in the 80s, and he published a randomized trial in between catheter-directed thrombolysis and IV thrombolysis. And well, he published this data in Circulation in '88, showing that there is in fact no difference in outcome in between catheter-directed thrombolysis and IV thrombolysis. And even if you add US-assisted systems to your catheter-directed thrombolysis, well, there's not too much data which show you that you might have benefit. So, as already Sanne mentioned in his talk, there are mainly three different large bore aspiration catheters, the Inari, the Penumbra, and then the Angiovex system. And most of the data, they are coming from the float reaver. So let's go through these data. Well, with the float reaver, you have different prospective studies, like the FLARE, FLASH, FLAME, PEERLESS, all very fancy names. But let's start with the FLARE trial. Well, this is a prospective, was the first prospective single-arm, multi-center trial of catheter-directed mechanical thrombectomy for intermediate high-risk acute pulmonary embolism. And in fact, it was a safety and efficacy trial. And well, these first data, well, they showed us that indeed this is a very safe procedure with a technical complications less than 2% of cases. In the large majority of cases, by the way, these procedures were done under local anesthesia. And also, it was quite surprising that the ICU stay was significantly reduced to what we expect with systemic treatments. And also, when we look then to the right-left ventricular ratio, then there was a significant drop when you do that thrombectomy, and also the drop is much more important than what you should expect after heparin administration alone. And also, especially then in these patients with pulmonary hypertension, there is also a significant drop in the pulmonary artery pressure before versus after the procedure. And that's also what we found in our experience, and I put it together, the results of our center together of another large center in Belgium, was in Brugge. We did most of our procedures indeed under local anesthesia. However, we also performed 12% of our cases under ECMO, meaning that the patients are already under ECMO, and then we did the thrombectomy with the ECMO in place. So this is also possible. And although it was not available in the beginning of our experience, the flow saver is now routinely used. And also we could nicely find that the the systemic and the diastolic pulmonary artery pressure is dropping significantly before versus at the end of the procedure. And post-procedural data also show that this is a very safe procedure with a very low number of major adverse events and no major bleedings. Maybe we were quite prudent in the beginning of our experience, meaning that the length of our ICU stay was a little bit higher than what you should expect. It was a median of 3 and a mean of 5 days. Then we go to the FLASH trial, and the FLASH trial was done in the US. There was more than 800 of patients included, so a very substantial number of patients included, over 50 US sites. And here, this was in fact a prospective registry on the use of mechanical thrombectomy with the Inari system. The large majority of these patients were intermediate risk patients. Only 8% were high-risk patients. However, 1/3 of these patients had a contraindication for systemic thrombolysis, and 1/4 of these patients at the baseline had a depressed cardiac index. And we find here more or less the same results as what we found in the FLAIR study, meaning that we have a significant improvement in the hemodynamics with a significant drop in the pulmonary artery pressure. And also after 48 hours, it's clear that also a lot of cardiac parameters, they are beneficial, like there is in 3/4 of the patients, there is no or still a very mild right ventricular dysfunction. And also the hospital stay is, at least hospital stay at the ICU is reduced to a few days. And when we look then more closer to the procedure itself, again, then we see that there is a significant benefit both in cardiac parameters as well as in pulmonary parameters, as shown in these diagrams here. And also, the majority of patients, again, had a significant drop in pulmonary artery pressure, making the hemodynamic status of the patient much better. Then we come to the FLAME trial, and what's the FLAME trial? Well, again, it's a prospective multi-center, still non-randomized trial where patients were treated with the flow retriever or with other contemporary therapies, meaning standard of care in the different hospitals, and this was then the context arm. And here again, so all-cause mortality was much lower in the flow retriever arm compared to the context arm, as well as patients which were clinically deteriorating after the primary treatment. This was very low in the flow retriever arm compared to the standard of care or to the context arm. And all these studies are becoming more and more interesting because now we are at the PEERLESS the trial, which is the first randomized trial. And here again, a substantial number of patients included, more than 500. And here, the flow retriever was randomized against catheter-directed thrombolysis. And as primary outcome, it was a composite of all-cause mortality, intracranial hemorrhage, major bleeding, clinical deterioration, and post-procedural intensive care admission and length of hospital stay. This was the flow chart of the study, showing that we had indeed, it was a 1-to-1 randomization, and patients had visits at 24 hours after the procedure, had hospital discharge, and also at 30 days after the procedure. And so a lot of diagrams, but it's clear here that this study met the primary endpoint here, and that you can see, if I can show you here. So the primary endpoint was met that it was significantly beneficial when you use the flow retriever compared to the catheter-directed thrombolysis, and also several cardiac and pulmonary parameters were in favor of the use of flow retriever system. And there are more studies ongoing, and these are, I think, the most interesting ones, like the PEERLESS 2 and the PERSEVERE trial, because here patients will be randomized in between aspiration thrombectomy and the real standard of care, which is anticoagulation, not only for high-risk patients, but also for intermediate risk patients. And as you see here on the slide, more than 1,000 patients will be included, and then I think we will have more or less definitive answer. Are we going for mechanical thrombectomy, or are we going for anticoagulation in the majority of patients with intermediate and intermediate high risk patients? Just a few words about another device, which is the Penumbra device, the Indigo. And also with the Indigo system, there are a few papers who already came out with the Extract, the Strike, and Storm and Cath PE are ongoing. And well, when we look to the Extract, well, in fact, it's a copy-paste of what we've seen in the FLAIR trial, meaning that we have a significant reduction in the right-left ventricular ratio, that the procedure is very safe, and that you can significantly reduce the intensive care stay of your patient. And the Strike study is not really already published, but although there's an ad interim publication, it was published last year. And of course, here it was a prospective, non-randomized trial, not only looking to cardiac and pulmonary parameters, but here, interestingly, they also looked to the quality of life after 90 days. And this is something new. And here also, all these graphs show you that there is indeed some benefit for cardiac pulmonary parameters, but also the quality of life, like mobility of patients, self-care, usual activities, pain, discomfort, anxiety, depression are significantly better when you use this mechanical thrombectomy device at 80 days of follow-up. So then I come to my conclusions. So percutaneous aspiration thromboembolectomy, well, today we have different devices on the market. They have all a very good safety profile. And today, already in many institutions, it is the treatment of choice for high-risk patients, especially if IV lysis is not an option or is not effective. It is superior to catheter-directed thrombolysis. And we are also all looking forward to the outcome of the data of these randomized trials, which are comparing aspiration thrombectomy versus standard of care anticoagulation. Thank you.
Maybe just one short question. Thank you for this excellent presentation. Results of the STORM PE trial have been published recently, which also showed a great increase in results for patients who received the thrombectomy. So I think that's a great step, and I hope when the ESC guidelines will get revised, hopefully in 2026, that we'll get more progressive guidelines. Yes?
Just a comment to your conclusion. Do you really think that for intermediate patient, IV lysis is really still something we should consider?
Sorry, can you repeat your question, please?
Regarding your conclusion,
yeah.
If IV lytic therapy is not an option for intermediate patients, so my question is it really still an option for intermediate risk patient? I personally believe definitely not.
For thrombectomy, you mean?
You stated IV lysis.
Yeah. Well, we still do in selected cases still IV lysis, not for intermediate risk patients, but for intermediate high risk patients. The real high risk patients, which is a very selected group of patients, there we immediately go for thrombectomy, and sometimes also immediately for ECMO, of course. But indeed, so for the low risk or the intermediate risk, I think the standard of care is anticoagulation without IV lysis. That's correct.
Okay, thank you so much. I'd like to introduce our next speaker, Mark Meisner from the United States and from Seattle, if I saw correctly. And he's going to show us a complication after a venous intervention. Thank you.
Thank you very much. And thank you for the invitation. Welcome, everyone.
I don't have any conflicts of interest. So we'll start with just a brief case. This is a 73-year-old female who presents with severe bilateral lower extremity edema. Had previously had a low-risk PE a couple years ago that she had an IVC filter placed for that was never retrieved. And as you can see, her venogram here shows a suprarenal extension of this filter-associated thrombosis. It was decided her symptoms were sufficiently severe to warrant mechanical thrombectomy. Does this patient need embolic protection? How many people think yes? 2 or 3? How many people think no? 1, okay. Great, then we'll try to answer some of the questions. So, pulmonary embolism after venous interventions is actually surprisingly rare. If you look at the best data, literature suggests that for superficial venous ablation, it's somewhere between 3 and 10,000, and in 1 in 1,000 patients will have a pulmonary embolism. For venous stenting, somewhere between 2 per 1,000 and 6 per 1,000. Then the data gets a little marginal. If we look at early thrombus removal, either lytic or mechanical, the rate is 1 to 2%. And given the short time, and that's where really most of these emboli are occurring, we're going to talk about that mostly. Clearly, the ATTRACT trial did show that there is some benefit from early thrombus removal and iliofemoral deep venous thrombosis, although the overall trial, which included both femoral popliteal and iliofemoral DVT, showed little benefit. Subgroup analysis of those patients with iliofemoral DVT is suggestive of a benefit. Among the 391 patients that were randomized, there was no difference in PTS of any severity between the two groups. However, if you looked at moderate to severe and severe PTS, defined as a Villalta scale of either greater than 10 or greater than 15, there was somewhere between a 7 and 10% reduction in these categories, and at least in the iliofemoral arm, there was in the overall trial, but in the iliofemoral arm, there was no increase in major bleeding associated with pharmacomechanical thrombolysis. So the findings do support percutaneous management of acute iliofemoral DVT in patients with severe symptoms and low bleeding risk, but there is no mention of PE as a safety endpoint in this subgroup analysis. It's not even mentioned, which is some of the problem with that. Since the ATTRACT trial, we've had an explosion of these mechanical thrombectomy devices, which serve to either macerate, aspirate, or fragment the thrombus, depending on the particular device, which does allow the potential for faster and more efficient thrombolysis, reduced lytic doses, if any lytic is required at all, and a lower bleeding risk. But it does raise the question with these mechanical devices, are we at an increased risk of pulmonary embolism with it? And there is some advantage to the mechanical devices. This was a propensity matched analysis done by Steve Abramowitz comparing the patients in the catheter-directed thrombolysis arm of ATTRACT with the clot registry, which used the ClotTriever system. And you can see the percentage of thrombus removal was significantly greater with mechanical thrombectomy, 87% versus 67%. And at 12 months, there was an improvement in Villalta score, about 80% of patients getting mechanical thrombectomy being free of any PTS versus about 63% of the patients who got catheter-directed lysis. And again, once again, missed this part. The advantages were 97% of the patients were treated in a single session. None of the patients required lytics in the mechanical arm, and the post-procedural ICU stay was required in only 2.3% of patients. But again, just as in the ATTRACT trial, there is no mention of PE as a safety endpoint. We don't know how often it occurred. We don't know how many people got embolic protection from this. Systematic reviews do offer maybe a little bit better answer to this. There's 3 or 4 out there. This is the best one by Michael Lichtenberg, who maybe can comment on it at the end. All of these are flawed by the data that goes into them. Again, many of these studies don't mention pulmonary embolism. Many of them don't say how many used embolic protection. But in this systematic review of 17 randomized or cohort studies comparing catheter-directed thrombolysis, THR in the diagrams, versus percutaneous mechanical thrombectomy, the overall quality of the data was quite poor with significant heterogeneity between studies. Again, many of these studies don't even recognize or mention a safety endpoint for pulmonary embolism. But you can see moderate to severe post-thrombotic syndrome was lower in those receiving catheter-directed catheter-directed thrombolysis, 13% versus 28%, 26% in those receiving mechanical thrombectomy, at the expense of an increased bleeding risk with catheter-directed lysis, 6% versus 1%. But the incidence in both groups of pulmonary embolism was quite low, 2% with catheter-directed thrombolysis versus 1% with mechanical thrombectomy, so quite low. So can we identify a high-risk group who does need embolic protection during these procedures? This is a study that looked at a number of risk factors in 266 patients undergoing catheter-directed thrombolysis. All of these patients had pre-procedural CT pulmonary angiography, and among a number of risk factors evaluated, really the only significant ones were history of cardiac disease and a silent pulmonary embolism on this preoperative imaging that were associated with a 10-fold increased risk of symptomatic pulmonary embolism and a 4-fold increased risk as shown here. But there's no evaluation of thrombus location or some other important risk factors in this study. But this data is consistent with the guidelines of the Society for Vascular Surgery and American Venous Forum, which are now quite dated. This is from 2012. These haven't been updated in over 10 years, but they recommend against inferior vena cava filters routinely for catheter-directed thrombolysis, but suggest that risks versus benefits be considered in those undergoing mechanical thrombectomy, those with thrombus extending into the inferior vena cava, and those with markedly limited cardiopulmonary reserve. And that's a weak recommendation based on poor quality evidence. So I think what we can take away from this is that clearly there is a role for proximal embolic protection, particularly in those cases with IVC thrombosis, IVC filter-associated thrombosis, previous pulmonary embolism, a history of cardiac disease, and maybe, I said question of malignant thrombosis. I'm still not quite sure about this, but my partners have recently reported 4 cases where they did recover malignant thrombus from the filter. I still think a lot of these ought to be managed with open surgery rather than percutaneously, but there is a role. The choices include IVC filter, a partially deployed wall stent, most commonly a 24/7, which is then recaptured at the end of the procedure. And although not available in Europe, the Protrieve sheath, which uses a 20 French sheath, deployed through the sheath 33 millimeter nitinol funnel, which is then recaptured at the end of the procedure. So to return to our case, this is our suprarenal extension of the IVC filter-associated thrombosis, partially deployed wall stent 24/7 in the suprarenal cava, and then aspiration thrombectomy here. The wall stent is then recaptured at the end, and this shows the final venogram. I'm going to say there's one final place where I think proximal embolic protection is almost always required, and that is in these chronically occluded iliofemoral venous stents. This is a study of 44 patients. All of these had some chronic material within the stent. Some of them had more acute symptoms with acute on thrombus, but all of them had chronic material. All were treated with mechanical extraction of this material with a RevCore device, again, not available in Europe, but you can see that this is effective completely or mostly restoring venous patency in over 90%. But the important part is all of these patients had proximal embolic protection, and embolic material was captured in over 80% of these, but there was no symptomatic pulmonary embolism. So I do think routine embolic protection is warranted in those patients, and I hate to call it mechanical thrombectomy because this really isn't thrombus. You're removing that chronic post-thrombotic debris from these stents with these devices. So in conclusion, venous interventions are associated with surprisingly low PE rate, although again, I think particularly for percutaneous thrombus removal, the data is very questionable because a lot of studies don't mention it as a safety endpoint, and very few studies actually acknowledge how many of these patients had embolic protection during the procedure. The poor quality data that there is suggests mechanical thrombectomy is not associated with a significantly higher PE risk, but I think that has to be taken with significant caution given the problems with the data. The guidelines that are mostly outdated need to be updated, but they do recommend against routine thromboembolic protection for catheter-directed thrombolysis. And I think what really needs to be done is we need to mandate that if you're reporting mechanical thrombectomy, you report PE as a safety endpoint, and you report how many patients in the studies had embolic protection. And I think we can conclude that there are some situations that clearly warrant embolic protection, IVC thrombus, IVC-associated, filter-associated thrombosis, previous history of pulmonary embolism, cardiac disease, maybe malignant thrombosis, and these mechanical thrombectomy, these chronically occluded stents. Thanks for your attention.
Thank you very much. Are there questions from the audience? I have a question. When you are doing these iliofemoral interventions at the end of each procedure, are you also checking the pulmonary circulation or not?
Not if the patient's asymptomatic. I've only had one patient who's developed symptoms during one, which we did do a pulmonary angiogram that was negative during the procedure, but if the patient's asymptomatic, no.
And then another question, what you typically find in your funnel or in your wall stent, are these large amounts of clots or only some small amounts, and then like what you showed us, it seemed to be quite old clots, in fact.
You know, I think it a little bit depends. I don't, mostly because I use the clot retriever device usually for iliofemoral DVT and don't use embolic protection with that. Often we use aspiration thrombectomy with the penumbra device for caval stents. And most of the time there's nothing in them. Occasionally you do see smaller clots in them. And you always question, it's of a size you wonder if it would be symptomatic if you didn't do anything.
Thank you. Very nice case. Just a question on the wall stent. I presume that would be an off-label use.
Absolutely. Yes.
Our radiologists are very reluctant to put in IVC filters above the renals because they worry about them migrating into the heart. So this is a typical case where there's obviously a risk of embolization, but to protect that is very challenging. So would you maybe just comment on the suprarenal IVC filters as opposed to the technique you used there?
You know, I agree completely on suprarenal filters for the average deep venous thrombosis. I have less of a problem if I'm going to retrieve it at the same time. That is, do the thrombectomy and retrieve the filter at the same intervention. And that I feel pretty comfortable with.
Thank you for a great case and great presentation. Sorry. I wonder if the type of catheter that you use would sometimes mandate whether you go with protection or not, or you just, if you do catheter-guided thrombolysis or any type of device, you'd not consider a filter in.
You know, there is no data, so it's only my opinion on that. But yes, I do think that particularly aspiration thrombectomy in the inferior vena cava worries me more, but there's very little data to support that. And maybe, Michael, if you wouldn't mind comment, you know, your data is the best data out there about this. What do you take away from your systematic review?
So the biggest challenge of this publication was the heterogeneity of the data. What is post-thrombotic syndrome? The definition goes from there to there. Yeah. So it's really difficult to compare these different trials and really define an endpoint. So this is one point. CDT therapy is effective but not safe. So why still using CDT therapy if we have effective therapy?
I tend to agree with that as well. I think there is a role for lysis as an adjunct to mechanical thrombectomy, but it's very rarely the first line study. I think part of the problem, if you look at the data, it's pre-proof right now, but Alan Davies did another systematic review that'll be out in the next couple months, in which they reported 2 fatal pulmonary embolism, one in the mechanical arm, one in the catheter-directed thrombolysis arm. But again, and I contacted the authors, they can't tell me how many pulmonary emboli or how many patients had proximal protection in their review of it. The data is just not there.
Okay, thank you very much. So I think that we can close here that first part of the session, and that we can now switch to the, let's say, the second part of the session, which is called the Inari Symposium. And it will be Dr. Michael Lichtenberg, who will give his presentation on the way he is treating acute DVTs. Please.
Yeah, thank you very much. Thank you very much for the invitation. By the way, congratulations. This is a great session, so I really appreciate that. So we recently published the ESVM guidelines updates, and I have two conflicts to tell you. First of all, this is a sponsored talk, and the second one is I'm co-author of this, so if you want to kill me, so this is the right moment. So where are we coming from? So Europe and of course United States as well has a high number of DVT cases. So on average we know, and this we recently published, one person dies every 6 minutes from a blood clot caused by VTE. And we know about the numbers, the high numbers of patients suffering from acute DVT. And from an economic standpoint, the costs are estimated around 3 billion in Europe. So this is a high number, and the question is, what can we do to improve the outcomes of these patients? Because I think we still do not have efficient therapies so far, and this counts as well also for your country, Mark. The standard of care is limited, the costs are high, and the guidelines, unfortunately, going from A to Z at the moment. So whatever you believe in, what politician party you believe in, you find everything. Yeah? So everything is in place. So, and we are coming from a very conservative way of treatment in Europe, I need to say. So we luckily have now a lot of options available, especially in terms of mechanical thrombectomy, available in Europe as well, of course, in the United States. So this is what I mentioned. These are the at the moment existing guidelines in terms of treatment of patients with acute iliofermal DVT. And these are recent guidelines. We are talking about guidelines from 2020, 2021, from different societies, and you find everything from, please do not ever consider a treatment in a patient from having an acute iliofermal DVT, you should evaluate and consider a treatment. So you find everything. And I think this makes it quite complex to really establish a recommendation for patients with iliofermal DVT. What we know, and Mark, you already showed this is another publication recently published, lysis versus anticoagulation in iliofermal DVT, what the RCT evidence really shows. You can see here, it clearly favors an early thrombus removal based on meta-analysis. So we should definitely take this into consideration, that a patient with acute iliofermal DVT has a clear improvement of the symptoms acutely, but on a long term also improves in terms of their post-thrombotic syndrome. So I think that is clear, and these are the data which now find place in the recommendations in the new guidelines, and this is a heads up of these guidelines which we just published. Mechanical thrombectomy is now a guideline recommended class 2A intervention for acute DVT because of safety and efficacy endpoints. And when we compare the treatment with anticoagulation, we can see the clear advantage of a really aggressive mechanical thrombectomy approach. So these are the guidelines, and let me concentrate this for a second. I know this session is running out in 3 minutes. So these are the cherry picks here of the guidelines. So in patients with severe symptoms due to iliofermal DVT and ilocalval DVT, catheter-based therapy should be considered. Class of recommendation 2A. Level of evidence A. So we have level A, just to remind you on this, are multi-center prospective trials, meta-analysis, are available for this recommendation of 2A, and 2A is in favor for. So I think it's worth that every patient showing up with acute iliofermal DVT should at least have an evaluation if this patient is a candidate for thrombectomy in acute iliofermal DVT. Class 1, the involvement of a vascular expert in this decision-making process is a high recommendation. So therefore, I personally believe we should establish centers of excellence in every country who see these patients. These are not super high emergency cases. I'm not talking about phlegmasia. I'm talking about a stable iliofemoral DVT patient. So why not sending the patient to a center to be evaluated if this is a candidate for thrombectomy? It is recommended that interventionalists with expertise in endovascular treatment of acute iliofemoral DVT are involved. Of course, it's not an easy, directly done case. It's a complex thrombectomy case, also with decision-making in terms of stenting afterwards. Do we have good inflow, outflow, etc.? So venous centers, in my perspective, should be established in regards to that. So for endovascular treatment of acute DVT, the use of catheter-based mechanical thrombectomy should be preferred over CDT. And this, I think, is for me personally the most important aspect of this guideline. CDT has to be stopped. And Mark, you nicely showed it. It's effective. Okay, it has this niche indication maybe for in-stent thrombosis as an adjunctive therapy, but not as a primary approach for patients with iliofemoral DVT. Efficacy based on the data may be acceptable, but the safety aspect is a no-go for CDT in my perspective, and reflected here in the guidelines for patients with acute iliofemoral DVT. And then let me just comment, intravascular ultrasound is a must, and this is the reason why I personally believe that venous centers with all the technical equipment should treat these patients. You should be prepared for all issues that can actually occur during such a case. And this is another important aspect, because this only shows class 1 recommendation in terms of these points. If stent placement is required, the use of dedicated venous stent is recommended. Interestingly, the level of evidence is C, so this is a consensus agreement, because there are no dedicated randomized trials, venous stents versus arterial stents. So actually, I think no one would do this in the future, so this is still level of evidence. But please, no more arterial stents. In patients undergoing catheter-based therapy with or without stent placement, full dose anticoagulation is recommended. I think this is clear. And what is also important is the follow-up of these patients. And then again, a clear argument for venous centers. It's not just a treatment and forget about it. It's a kind of lifelong follow-up of these patients. They typically receive a stent, IVUS-guided stent implantation, so they need a very precise follow-up. And therefore, this is also mentioned here, we as the ESVM group thought that it is important to establish venous center. However, this is difficult definitely to define, but I think we should use these guidelines to implement venous centers in European countries, because with that, I believe we can improve the clinical outcome of the patients and definitely reduce the post-thrombotic syndrome rate of our patients we are still seeing. I know that this guideline, especially in some countries, I'm not mentioning one country, but maybe in one country, caused some issues and a lot of discussion, but guidelines are scientific papers to discuss. We are moving forward this story, and I think it's clear now mechanical thrombectomy is the way to go. Establishing venous center, this is the way to go, and I hope we will see these centers very soon. Thank you very much.
I hope you enjoyed the rest of your conference and your stay here in Paris. Thank you so much.